So physiologically, this is what happens if you pardon my drawing, but nevertheless, the left atrial blood flow can't get into the left ventricle because the left ventricle either has no inlet or has no outlet or has neither, and therefore has to cross through, in this case, the foraminal valley, all mix in the right atrium, which then enters the only functional ventricle, which is, in this case is the right ventricle, pumps out to the pulmonary artery. Some of the blood flow goes to the lungs, some of it goes to the body, into the entire aorta. Prograde down the descending aorta, retrograde into the arch and ascending aorta. The management of these children obviously is to balance their circulation. First of all, this is one group of children as a single ventricle. Their reason they don't develop congestive heart failure in the classic sense of having too much volume in their vasculature. The reason why they get into trouble is because that blood flow is not going to the right place. In other words, the lung resistance has gone down. They're getting too much blood flow to the lungs. They're getting less blood flow to the body. That's why they get into trouble, not because they're volume overloaded. And so that fluid restriction, which is the management of children who have true congestive heart failure, should never be done in these kids. In fact, you should really optimize the preload. And then what you have to do is maintain the pulmonary vascular resistance. If you maintain their neonatal pulmonary vascular resistance high, they will balance themselves. So avoid oxygen, even though their saturations typically are in the 70s or 80s. That's where they ought to be, somewhere in the 70s or 80s. And you avoid hyperventilation, which also drops their pulmonary vascular resistance. So intubating these kids, giving them oxygen, hyperventilating them are all the worst things you can do, because you will drop their pulmonary resistance, flood their lungs, rob the blood flow from their systemic circulation. Remember, they're in parallel. Now, what operative alternatives do we have? Well, I'm going to talk about the palliative operative procedure. It's all palliative in a broader sense. But palliative procedure, which is the so-called Norwood Stage 1 procedure, as was described early on here, obviously the other alternative is to transplant these children. And I'm not going to talk about transplantation. I think that's going to be covered in another area. Really, the only difference in transplanting these children versus any other type of transplant is that, unlike the usual transplant where you can do an aortic end-to-end anastomosis, in these children you need to use the entire ascending aorta of the donor, and you need to patch the entire transverse arch, because remember, they have coarctation and hypoplasia of the transverse associated with it. So that when you do a transplant in these children, you need to deal with the entire transverse arch. That's the only difference. Everything else is the same. So as far as palliative procedures, the concept of the Norwood procedure is to maintain their parallel circulation initially, because there's nothing else that you can do. The problems that they have is that they have a ductus, which is providing systemic blood flow, which obviously is going to close as soon as you stop their prostaglandins. And so that what you want to do is, in fact, eliminate ductus as your limiting factor. So what people do is they divide the pulmonary artery, leave the branches separate, and connect the main pulmonary artery to the entire ascending aorta and arch. And typically you need a gusset of some material to bridge the gap. Most commonly nowadays, pulmonary homograft is used. Without the valve, obviously, just the pulmonary artery is used. And then you provide blood flow to the lungs via a shunt. Here they're showing you is a classical Blaylock. What most people do nowadays is just modify Blaylock with Gore-Tex. Make this small enough so that they provide adequate blood flow to maintain reasonable oxygenation, but so that they don't flood their lung. And that's the tricky part. And that's really been the tricky part of all of this, is the size of the shunt. Nowadays, most people use a 3.5 millimeter Gore-Tex 2 coming off, just as is shown here, except it's not divided subclavian, but coming off the underside of subclavian to the confluence of the pulmonary arteries. Well, what has this achieved? Not very much, in fact. All it's done for these kids is that, A, their pulmonary artery now connects to the aorta directly so that they're not duct dependent, so you can stop the prostaglandins. And B, even if they drop their pulmonary resistance, the pulmonary blood flow is still going to be limited by the physical size of your shunt. So now you've maintained the balance, this time by a physical measure rather than by pharmaceutical or other manipulations. But that is also the reason for the high mortality, because you're doing this huge operation, typically with a long period of circulatory arrest, and yet when you're done with the operation, you've got the same exact physiology that you started off with. Okay? And that's why there's a very high mortality with these children. That's improving as the techniques of the procedure have improved, but nevertheless, it still is probably the biggest single challenge to congenital cardiac surgeons. The technique has evolved. This is from Norwood's Atlas of Surgery. His procedure, as he's doing it now, is pretty much the same in concept, slightly different in actual technique, division of the pulmonary artery. Once you've circulatory arrested and have near the arch, close off the main pulmonary artery on the distal end and ligate the ductus, and then you use a gusset of material to connect the pulmonary artery to the transverse arch. In this case, he's using a pulmonary artery homograph as a patch. You need to go beyond the coarctation or duct tissue to enlarge this area. And eventually you bring it all the way to the main pulmonary artery. Here he's showing the pulmonary blood flow coming from a small shunt from the underside of the arch. Most people don't use this anymore, but they simply go from the clavian artery down to the pulmonary artery with a Gore-Tex tube, and this is the completion of the procedure. So now you have MPA connecting to the entire ascending aorta and transverse arch via the gusset, pulmonary blood flow regulated by the shunt. Subsequent steps to the procedure. Most people do an intermediate step now because you're trying to get to a Fontan operation, and the intermediate step is a bidirectional Glenn. In this case, what they're showing you is all the variations on the bidirectional Glenn. Most people do this variation here in this division of the superior vena cava, connecting it to the roof of the pulmonary artery at the time that you take down your Blalock shunt and you close off the atrial end of the SVC. What does that do now? All of your superior caval blood flow goes into the lungs, and there is no other source of pulmonary blood flow to the lungs. Okay? In small children, that's adequate. Now, is there enough blood flow in SVC to saturate them sufficiently so that they can actually function pretty well, and they can actually be fairly active? And the reason for that is, if you think in terms of the surface area distribution in a child versus an adult, the child's head is much bigger with respect to their body, and so that in fact the SVC carries about 50% of their entire blood flow, as opposed to an adult, which carries only about 30%, and actually some species of adults where it carries very little, in actual fact. So that's why in children you can get away with this procedure. It's also the reason why in older children the procedure doesn't work very well. It doesn't oxygenate them efficiently. And so you need to go to the next step, which is usually done as a third stage in children, and that is that diversion of now the inferior vena cava blood flow through an opening in the roof of the atrium towards the confluence of the pulmonary arteries, and you use an interatrial tunnel. In essence, here is usually used Gore-Tex to divert the inferior caval blood flow laterally out to the confluence of the pulmonary arteries. And now you finally established in-series circulation. Why? Caval blood flow, superior and inferior cava, has to enter the lungs before it actually gets back into the heart and it's pumped out into the body. So now you have the systemic venous blood going to the lungs first, then back to the heart, and then being pumped out to the body. That's the first time these children have ever seen in-series or normal pulmonary blood flow. Is it a correction? No way. You still don't have two ventricles. Okay? Does it work? Yes. The vast majority of these children, it works well. Occasionally you have problems with very high caval pressures because the pulmonary resistance is high, in which case what you can do is punch a little hole in this patch, typically about a 4 millimeter hole, so the so-called fenestrated Fontan operation, and that allows some desaturated blood to get into the left atrium. These children aren't 100% saturated, but in fact their cardiac output is adequate. So this is the current state of the art as far as the management of hypoplastic left heart. And as I said, this is still perhaps one of the most challenging areas. I believe the longest term survivor is actually being followed in Boston, and is a 12-year-old child, over 13-year-old child, who's gone through all stages of the procedure. Okay? But if you look at in fact, in this year's supplement to circulation, in the Cardiovascular Surgery 1994 issue, the Boston group describes their entire experience with this whole approach, and going back to the original operations that Norwood did back in the early 80s. And so probably the honest report. And in fact, you see that in certain anatomic subgroups, such as mitral stenosis and aortic stenosis, the long-term results are very good. About 70% of kids are alive beyond 5 years. In the other groups, you have mitral atresia and aortic atresia, where the ascending aorta is tiny, and they have a number of other problems. Long-term survival is about 30%. So they are heterogeneous within their groups. One of the risk factors tends to be size of the ascending aorta. The other risk factor is how you get them to the fontaine. If you try to go in 2 steps, mortality is very high. If you go in 3 steps, that is, interpose a bidirectional Glenn, mortality seems to be much lower. But a long way of answering your question, and that is, we don't know. But this is clearly a palliative approach. The results with transplantation are still not, we don't have too many centers that are reporting the results. But if you look at, other than the Loma Linda experience, which is unique in that they tend to have the best results, most people are reporting about a 60% 5-year survival in neonatal heart transplants. And that's if you ignore the fact that you lose about a third or half of these kids just waiting for a heart. So if you throw that number in, the results are about equivalent. Okay? Okay, the last topic I'm going to cover is perhaps one of the most confusing areas for not only adult cardiac surgeons, but for pediatric cardiac surgeons. But again, there are some basic principles you ought to remember, and I'll try to point those out. But it's important for you to at least understand one of the types of vascular rings, again, because it inevitably comes up in your boards, and I'll try to show you that one. Now, I've given you this diagram in your outline, and the reason why I've given it to you is because you ought to remember that in the embryology of a human, there are 2 sets of arches, and very early in development there is both a right and a left set of arches. These join typically at the level of the diaphragm, or what later on develops as the diaphragm, and the process of how we normally develop our arch is in fact involution of one side or the other. In the vast majority of humans, the right side is what undergoes involution. Occasionally, kids, you see that the left side is what undergoes involution, and they have a right dominant arch. In the vast majority of people, the left side is dominant. The ductus is really the 6th aortic arch, and from that come the pulmonary arteries. Now, if you want to get all the questions they're going to ask you in your boards, you can memorize all of these arches. Otherwise, forget about this, other than to remember the very simple concept, that is that this is why you can develop a right aortic arch if you have involution of the left side, or in the normal situation, involution of the right side is what occurs. And therefore, the left side arch is the only thing that remains once the child is born or as an older fetus. And that each part of the arch, of the transverse arch, is comprised of one of these older arches. So that as you get older, one side becomes atretic, and now the subclavian artery is a branch, the right subclavian artery, which was originally part of the right bronchial arch, in fact becomes the true right subclavian. And when you look at the normal adult anatomy, in fact the right subclavian is still part of the original right aortic arch. The transverse arch is comprised of various segments of the previous arches that have simply fused together. Now, why is that important? It really isn't all that important, other than to remember that this process occurred, and therefore, if you have involution of anything other than the normal situation, then you have the potential for vascular rings. If you have no involution of any of these structures, then you have what's called the double aortic arch. And the most common vascular ring you'll see is the double aortic arch. And the reason for that is that it is just lack of involution of any of the arches. Why is that important? Because these structures wrap around the trachea and esophagus. And so that when the child is born, the trachea and the esophagus, for that matter, is very tightly circumscribed by these 2 arches. And that's what gives them their problems. It is also the reason why if you have abnormal involution, you can have a subclavian artery which can evolve from, rather than as a branch of the innominate artery can actually come from the descending aorta and is called an aberrant right subclavian, because instead of this segment undergoing involution, in fact this segment undergoes involution, and therefore this connection is lost, this connection persists, and that's what ultimately feeds the right arm. And that's what aberrant right subclavian is really all about. It's just simply abnormal involution of the normal double arch structure which is present very early in the fetus. But it is not a vascular ring, as I'll show you in a minute. Okay, again, getting back to Netter. Netter, again, has some of the best pictures on vascular rings that you'll see. Normal anatomy, I talked to you about already, as far as the transverse arch. Aberrant right subclavian is simply a subclavian artery which arises distally beyond the left subclavian now. So it's at the place where the normal two arches came together as a fetus in the back of the chest. But the original connection between this vessel and the innominate here is gone. And that's what was abnormal. But otherwise, this is otherwise a normal situation, and at least shouldn't cause you any problems unless an adult subclavian becomes aneurysmal and gives you dysphagia. Otherwise, it is not a complete ring. There is no ring here. In other words, the connection between this artery and this artery is gone, so there's no true ring wrapping around the vascular structures. So this is not a ring. Situations where you do have a ring is, as shown you here, is persistence of both arches. This is looking at it from the front. Most of the vascular rings that you see are persistence or dominance of the right aortic arch, with the left arch still either being present or a ligament of it still being present. Okay? In other words, this is exactly what's shown here is a right aortic arch, which is dominant. There's still a left arch present there, although it's smaller of the two. The branching pattern of the aorta is very different in that all four vessels come out separately. So the first vessel coming off is the left carotid artery, then left subclavian. First vessel coming off right arch is the right carotid artery, and then right clavian. So essentially you have all four vessels coming off separately. In the back, these two arches join behind trachea and esophagus. Okay? So in essence, they strangulate both the trachea and the esophagus. This is another type of angiographic picture you ought to remember. This is an ascending aortic angiogram in a child with a double aortic arch, and this is the classic picture. The right arch here, left arch here, arch vessels from the right side, arch vessels from the left side. Notice that this side is larger slightly than this side. And that's true in about 3/4 of these patients, or 2/3 of them. It is the right side is the dominant one. Okay? Lateral view of this is exactly as shown here. And this is perhaps the way most of the time these kids are picked up, and that is by a barium swallow. In this situation, they actually did both an angiogram and a barium swallow at the same time. So they're really torturing this poor kid. But just to demonstrate the fact that, in fact, both arches wrap around the esophagus here. But what you see almost invariably is posterior indentation of the esophagus on the lateral view. And that it's a persistent posterior indentation. And that's almost always a double aortic arch in this situation. Now, it's important to remember that in this case, in fact, both arches are persistent. In other words, they have lumen to them. You can still have a ligament, so that there's no lumen, but there's still a ligament in any segment, anywhere along one of these arches. Okay? The symptoms will be exactly the same. These kids will still have strangulated esophagus and trachea, but when you do an angiogram, you don't see both arches completely. You see a bump here where the innominate, where what looks like an innominate artery arises, and you'll also see a bump posteriorly in the descending aorta where the other part of the arch joins, but nothing in between. But that's still a double aortic arch, except the segment. So it's still lumped in the same category, and as far as from the surgical standpoint, the approach is exactly the same. And I'll go over that in a second. The surgical standpoint is almost always with the vascular rings is a left thoracotomy. Classic question on your boards. Which side do you go into for a vascular ring? 99.5% of the time, you go in on the left side. just like a coarctation repair. Why? Because virtually everything that you have to do can be done from the left side. There's only one exception, which I'll mention in a minute. So it's a left thoracotomy, and in this situation, what I've shown you is the transverse arch, shown you here, left subclavian artery here, and the right aortic arch came around the esophagus posteriorly and is only held here by these strings, attaches to the descending aorta here. Ductus is up anteriorly in normal position, so that the operation is division of the arch. In this case, the dominant side was the left arch, so it's an unusual situation. Most of the time, it's the right arch that's dominant. Nevertheless, the division of the arch is still the same. If the right side is the dominant one, you divide the left arch right here. But the idea is divide them where the two join together. If you don't do that, if you start dividing them somewhere up here, you're still going to leave them with some degree of obstruction. Why? For the simple reason these structures are associated with a lot of ligamentous fibrous bands, which you can see right here. And these bands, in actual fact, can give you much of the constriction that gives you the symptoms. So that just because you divide the arch doesn't always get rid of all the problems. You have to dissect the esophagus free, you have to dissect the trachea free of these bands in order to relieve all symptoms of these children. The operative procedure is division of the arch, typically at the junction where the two arches meet. And which side do you divide? You divide the small side. And that's pretty straightforward. Most of the time it's going to be the left side because it's usually the non-dominant side. Occasionally, as is shown you in this picture, it's the right side that gets divided. If you have a ligament instead, in other words, let's say this structure here was just simply a ligament rather than a true vessel, the operation is still the same. You still divide that ligament, but you have to break this ring somewhere because this is a true ring wrapping around airway and trachea. Okay, other types of vascular ring, uncommon but can occur. Again, this is another picture of Netter. This is a double aortic arch shown here, and this is with the trachea and the esophagus gone, but showing you very nicely both arches. The other situations that you can see is a situation, typically again down here, with a right aortic arch. Again, most of these lesions have a right aortic arch being dominant. And in this situation, there is an aberrant left subclavian now, so it's mirror image situation. So right aortic arch, aberrant left subclavian, except the ductus comes off the underside of that left subclavian. Okay? So that makes a complete ring. Pulmonary artery anterior, as well as ascending aorta. On the right side is the transverse arch. Posteriorly is the descending aorta, as well as left subclavian. And then on the left side is this ductus, or ligament, in these children. And that completes the ring. Okay? That's the second most common type of ring. And the operation is still left thoracotomy. In this case, all you have to do is divide the ductus. Here, you can't just ligate it, obviously. You have to divide it because that's what breaks open the ring. Okay? Those two types of vascular rings will account for virtually almost more than 95, in fact, more than 95% of all vascular rings you'll ever see. The difference is up here is that sometimes these segments tend to be atretic, but nevertheless the anatomy is exactly the same. Here is ductus that's the problem. Okay? The only situation where a left thoracotomy is necessary is the mirror image of this. In other words, where the arch is left-sided, the aberrant subclavian is right-sided, and the ductus comes off on the right side. That's the only time you ever have to do a right thoracotomy, is the exact mirror image of this situation. And that's less than half of 1% of all the kids with vascular rings. So it's really almost never required. Most of the time, hopefully, they figure that out ahead of time so that you don't do a left thoracotomy and find yourself in trouble. Okay, I'm not going to cover these other lesions. And again, just to reiterate, aberrant subclavians by themselves are not complete rings unless the ductus comes off from them. Okay? And then the final types of vascular ring you ought to be aware of is the so-called pulmonary artery sling. It's not now an aortic anomaly, but it is an anomaly of the pulmonary artery. In virtually all the aortic vascular rings, The best way to diagnose it, other than symptoms and bronchoscopy, is a barium swallow. It'll tell you that there's something wrapping, vascular structures wrapping around the esophagus. This is the one situation where it won't. Why? Because here what happens is that the pulmonary artery, instead of giving rise to both branches, in fact, only gives rise to one branch, the second branch taking off from that distal branch. In other words, main pulmonary artery, here it's the right pulmonary artery going off towards the right. The left actually comes off the branch of the right, wraps this time between trachea and esophagus, and goes over to the left side. Okay? Very high association with tracheal anomalies, that is complete tracheal rings or some sort of tracheal anomaly. And these lesions generally tend to present as neonates. Again, to reiterate the anatomy here, main pulmonary artery, in this case giving rise to the right pulmonary artery, and the LPA is actually a branch of the RPA which wraps itself around the trachea so that it actually goes between trachea and esophagus. That's what pulmonary artery sling is. The operation is either division of the trachea if you have a tracheal anomaly, resection, or some sort of procedure to repair the tracheal anomaly and let pulmonary artery, the left pulmonary artery, swing anteriorly, or alternatively detach the pulmonary artery here, reattach it to the main pulmonary artery, and then deal with the trachea if you have to. But again, it's a very frequently associated problem, congenital tracheal stenosis with pulmonary artery sling. So, three things you need to remember about vascular rings are A, remember that normally you have two sets of arches, right and left, very early in fetal physiology, fetal anatomy. Typically the right arch undergoes atrophy and involution, but if it doesn't, then you have a persistence of both arches, and that gives you the rise to a double aortic arch. If only parts of it become atretic, but a ligament persists, you still have the same problem, except you don't see blood flow there. Okay? And that accounts for the vast majority of the cases. And the other cases is where you have a right aortic arch, aberrant left subclavian, and a disc coming off of it. And then the rarest of all lesions tends to be this one, which is pulmonary artery sling.
You will be aware that there are many and varied congenital cardiac malformations. Most of them probably come into the realms of esoterica, and there's no way that I can discuss with you the morphology of all of these lesions. So what I've chosen to do this year is to select what I think are the four most important lesions that you'll be discussing today. You see them on the board. And I'll try and devote 15 minutes or so to each of these topics so that at least we can try to do these important topics the justice they deserve. I think there's no question that the most important defect confronting all of you in congenital cardiac surgery is the hole between the ventricles. I'm going to talk to you in the limited time available about what might be called isolated ventricular septal defect, a ventricular septal defect which does not have other major associated malformations, but the morphologic details I will discuss are equally applicable when, for example, the ventricular septal defect is found in double outlet right ventricle or in common arterial trunk. Dr. Del Nido, when he was talking to you yesterday about atrial septal defect, made a very important point when he commented that you will find as many classifications as textbooks that you choose to open. And it's much the same with ventricular septal defect. And I think that the reason why there are so many classifications for ventricular septal defect, which after all is a relatively simple lesion, a hole between the ventricles, the problem with these many classifications is that there are multiple features that require description. In any individual case, if you are going to describe precisely the hole between the ventricles, it's probably necessary to give details of all of these features. I think it's exceedingly difficult to put all of that information into one classification, particularly if you then try to compress that classification into alphanumeric codifications. I dislike alphanumeric codifications intensely. I try as far as possible not to use them. And my preference is to describe what is going on rather than try to fit them into classifications, although, as you will see, there are some classifications amongst the slides I will show you. But the important features are first the borders of the defect, then the way it opens, and here with both borders and opening I've emphasized as seen from the right ventricle. In many instances it is now from the right atrium because you approach through the tricuspid valve, but effectively you're looking at it through the right ventricle. And then you need to take particular cognizance of septal malalignment. And if you can combine all of these features into a system of analysis which then points you to the location, crucial conduction tissue, then you're home and dry with determining the most appropriate way to close the defect. So this is the way that we group the defects together according to their anatomic borders. In my experience, all defects can be placed into one of these three groups, and this is the classification which as I say, does emerge from our own approach to defects. The overwhelming majority are found here related to the area of the membranous septum. They do not exist simply because the membranous septum is absent. They exist because the muscular septum is deficient in the environs of the membranous septum. And that is why we choose to call them perimembranous, around the remnant of the membranous septum, which may be the atrioventricular septum, but oftentimes is the remnant of the interventricular membranous septum. They are the commonest defects. Well, they are the commonest defects that confront you as surgeons. Probably in natural history, the commonest defects are muscular, which can be dotted around the muscular septum, but most of those probably close spontaneously. So it is less usual you are called upon to close surgically a muscular defect. The most interesting defects anatomically are the third group, which are found beneath not only the pulmonary valve, but in the back of the defect, the aortic valve, and we call those, rather a mouthful, doubly omitted and juxta-arterial. You may know them as subpulmonary or as supracristal. Now, if we look at the anatomy of those defects and we try to select from the anatomic features one feature which is the hallmark of each of those groups, you see that hallmark on the slide now. The essence of the defect that we call perimembranous is in the normally constructed heart that there is fibrous continuity between the leaflets of the tricuspid and the aortic valves. If there is such fibrous continuity, then the defect automatically is perimembranous. The second group, very straightforward. They have exclusively muscular borders when seen from the right ventricle. The feature which distinguishes the third group is that there is fibrous continuity in the roof of the defect between the two arterial valves. And this group can extend so that this fibrous continuity also involves the tricuspid valve, and so doubly committed juxta-arterial defect can additionally be perimembranous, or as I will show you shortly, it can have an extensive posterior-inferior muscular rim. So here I've opened a right ventricle from its apex, and I'm looking up towards the area around the membranous septum. Here you see a remnant of the interventricular membranous septum. This is the area of the atrioventricular membranous septum. And you see an extensive defect within the inner heart curvature where there is fibrous continuity between the leaflet of the tricuspid valve and the aortic valve. So this is the anatomic feature which tells us that this defect is perimembranous. I should say in passing that all of the pictures I'm showing you at the moment are taken from the excellent collection at the University of Pittsburgh, where I visit most summers. I'm very grateful to my colleagues at the University of Pittsburgh for letting me photograph these hearts and to use them in my various works. Here is a muscular defect, very straightforward, easy to recognize. Here is the right atrium, tricuspid valve. Here is the hole between the ventricles. And clearly, this relatively small defect is confined within the musculature of the septum and has exclusively muscular rims. And here again is the most interesting defect. The defect which is doubly committed beneath both the aortic valve and the pulmonary valve. You see the aortic valve through the defect. It is also juxta-arterial. It is directly against the leaflets of the arterial valve. Its anatomic feature is that there is fibrous continuity between the two leaflets of the aortic valve and the facing leaflets of the pulmonary valve. There is absence of the muscular outlet septum. But there is much more than that in this heart. There is also absence of the muscular subpulmonary infundibulum. So developmentally, this defect is remarkably similar to common arterial trunk, except that in the heart with the doubly committed and juxta-arterial defect, there are separate pulmonary and aortic valves. Note in this case there is an extensive muscle bar here that separates the edge of the defect from the area of the membranous septum. These are the two limbs of the septomarginal trabeculation, septal band. Posterior limb has fused here with the inner heart curvature, and this thick muscle bundle protects the conduction axis. We will talk about this muscle bundle very shortly in the setting of tetralogy of Fallot. These defects can open to different parts of the right ventricle. Obviously, the doubly committed defect has to be an outlet defect, although it can extend so as to open also to the inlet and then call it confluent. But the perimembranous or the muscular defects can, in different hearts, open to the inlet, open towards the apex, open to the outlet. So to describe them fully, we have to add on to the description of the anatomic borders the direction of opening within the right ventricle. This picture of a heart with a very small perimembranous defect reflects very closely the diagram you have in your notes as Figure 2. In the past, we used to draw lines across the septum in this fashion, and we used to say this is the outlet septum and this is the inlet septum. We now know that that is incorrect because, as I showed you yesterday, because of the deeply wedged location of the aorta, much of the septum separates inlet of right ventricle from outlet of left. And also, as you are well aware, most of this area is not a septal structure at all. It's the freestanding subpulmonary infundibulum, and this important structure here is also not septal. This is the ventriculo-infundibular fold, part of the inner heart curvature. So we now describe these defects as opening towards the outlet of the right ventricle in this particular case, also being perimembranous because there is aortic to tricuspid fibrous continuity. So here is another very large defect, extending from here all the way up to here, shielded by the septal leaflet of the tricuspid valve. If you lift this leaflet, you find the aortic tricuspid continuity. So this perimembranous defect opens to the inlet. This one is equally perimembranous. You can see there is extensive fibrous continuity here between the leaflet of the aortic valve and the tricuspid valve. this defect has no relationship to the inlet of the ventricle. It opens towards the outlet, but again is a perimembranous defect. So we must describe both anatomic borders and direction of opening. And so you have no problem then recognizing these as muscular defects opening to the apex of the ventricle. An interesting point about this type of defect is that when you look at it from the right ventricle, it seems there are 3 separate holes, but in fact this is a solitary defect seen from the left side, crossed by right ventricular trabeculations. And that's a relatively common feature. Now, septal malalignment is yet another feature that requires description. And there are 2 types of septal malalignment. The outlet septum can be malaligned. Very shortly we're going to talk about tetralogy in detail. I've already shown you yesterday how the outlet septum can be deviated and malaligned, produce subaortic obstruction when there is coarctation and interruption. But remember, that is only one form of malalignment. Equally important is the atrioventricular malalignment that I showed you yesterday in the setting of atrioventricular septal defect. That is equally important in separate valvar orifices with straddling and overriding the tricuspid valve. This is tetralogy of Fallot. We'll look at this in detail shortly, but now we can see the outlet septum. I've sectioned this heart to replicate the oblique subcostal cut taken by the echocardiographer, and you can clearly see the plane of the outlet septum is at right angles to the rest of the septum here between the limbs of the septomarginal trabeculation. So here is rightward deviation of the outlet septum. Here is a heart which demonstrates the type of malalignment I illustrated to you yesterday with the diagram. You'll appreciate we're looking at it from the left ventricle. Here are the papillary muscles of the mitral valve. This narrow slit here is the subaortic outflow tract, and this is the deviated outlet septum. You can often pull that forward just with a stitch, as I indicated yesterday. We always see the worst end of the spectrum in the autopsy room, so in a heart such as this, it may well be necessary to make a little nick here so that you can pull the deviated septum forward. But this is the type of deviation that goes along with obstruction to the left ventricular outflow. And then this is the particularly important type of malalignment you must recognize. You're looking here from the right atrium. Here is the office of the tricuspid valve. This is the ventricular septum. And you can clearly see that the tricuspid valve is attached in part to the right ventricle, but here, across the septum into the left ventricle, there is straddling and overriding of the tricuspid valve with the important corollary feature, malalignment between the atrial septum and the ventricular septum. All of this is important for determining the location of the atrioventricular conduction axis. Always the conduction axis posterior inferior to the perimembranous defect, irrespective of whether those defects open to the inlet, to the outlet, or are confluent. Conduction axis varies in relationship to muscular defects, but the most important muscular defect to recognize is the muscular inlet defect, because the conduction axis is anterosuperior to that entity. And then, as we already discussed yesterday, when there is atrioventricular septal malalignment, then there is an anomalous posterolateral node. So this old slide has stood the test of time very nicely. It shows you the view of ventricular septal defects as you would see them approach through the tricuspid valve. Whenever a defect is perimembranous, the conduction axis is posterior inferior to your right hand as viewed through the tricuspid valve. You must distinguish a perimembranous defect here from a large muscular inlet defect, because when there is a muscle rim in this location, the conduction axis will be to your left hand as viewed through the tricuspid valve, and clearly this has very important connotations for the location of your stitches. Equally important, straddling and overriding of the tricuspid valve. I've been told in the past that some people find this slide a little difficult to follow. So what I'm trying to show you here is the heart as you would see it on the operating table, and we're looking at it through an incision in the right atrial appendage. You're looking down on the orifice of the tricuspid valve, which is attached in part to the right ventricle and in part to the left ventricle. And if you took this view, when the ventricular muscular septum is malaligned relative to the atrial septum, you will see the malalignment, and you identify the point at which the muscular septum comes up and meets the atrioventricular junction. It is at the point where the septum meets the atrioventricular junction that you find the anomalous atrioventricular node, and with this entity straddling and overriding of the tricuspid valve, the node at the apex of the triangle of Koch is no longer the connecting node. So a very important distinction to make, straddling and overriding of the tricuspid valve. Now it's just a very short step to move from ventricular septal defect to tetralogy of Fallot. Etienne Louis Fallot, over a century ago now, defined this entity, which we can still recognize remarkably well by taking the combination of features that he identified: ventricular septal defect, a connection of the aorta within right and left ventricle, subpulmonary stenosis which was muscular in nature, and then the hypertrophy of the right ventricle, which was the consequence of these anatomic features. We now know we need to add to that the most important associated feature, whether the pulmonary outflow tract is stenotic, as it is in regular tetralogy, or whether it is atretic, forming the most important group of what might be called pulmonary atresia with ventricular septal defect, but is this group, tetralogy with pulmonary atresia, which have the crucial additional features of aorto to pulmonary collateral arteries, which I will show shortly. And unequivocally, tetralogy with pulmonary atresia is a most important group in its own right. In all of these hearts, we as anatomists try to pick out one feature which serves as anatomic hallmark, and for tetralogy, the feature which unifies these hearts, whether they have pulmonary stenosis or pulmonary atresia, is that the outlet septum, muscular bar separating the subaortic and subpulmonary outlets, is inserted anterocephalad in front of the anterior limb of the septal band, septomarginal trabeculation. But we have to add a rider to that, because this feature exists together with muscular subpulmonary infundibular stenosis. Why do I say that? Because you will come across hearts like this. This again, a heart from the Pittsburgh collection. I've cut across to replicate the oblique subcostal view taken very frequently by the echocardiographer. And we can see that the aortic valve here unequivocally is overriding the ventricular septum. There is a biventricular connection of the aortic valve. There is a degree of right ventricular hypertrophy. There is unequivocally a ventricular septal defect here, which is perimembranous. And the outlet septum, which you see here, separating the subaortic and the subpulmonary outlet, is unequivocally deviated anterocephalad relative to the septal band. But this heart does not have subpulmonary stenosis. Indeed, the pulmonary trunk is dilated, and in this particular patient was pulmonary hypertension. This is the entity that in the past was called the Eisenmenger malformation, and it has an anatomic hallmark for tetralogy of Fallot, anterocephalad deviation of the outlet septum. And that is why, to define tetralogy of Fallot, in addition to this anterocephalad deviation, we have to add muscular subpulmonary stenosis. So the additional feature which gives us tetralogy of Fallot, which you see in this also old slide, one of Anton Becker's, but again one which has stood the test of time well. We're looking from the apex of the right ventricle. Here is the tricuspid valve. Here is the aortic valve overriding the crest of the ventricular septum. Here is the septal band, the septomarginal trabeculation. The outlet septum deviated anterocephalad, but now unequivocal subpulmonary stenosis due to the hypertrophy of these septoparietal trabeculations. Properly to describe the variation in these entities, we need to distinguish very clearly various muscle bundles which surround the ventricular septal defect. In your notes you have more detailed definitions of these various entities, and we distinguish between the muscular outlet or infundibular septum, an intracardiac structure which never carries conduction tissue, and which separates the subpulmonary and subaortic outlets. We must now distinguish that also from the freestanding subpulmonary infundibulum. The second important feature, I've already mentioned, the ventricular infundibular fold. That is part of the inner heart curvature. If you go through the ventricular infundibular fold, you go outside the heart, and immediately outside the heart you will find branches in tetralogy of Fallot of the right coronary artery. The septomarginal trabeculation, the septal band, which has anterior and posterior limbs, the ventricular septal crest, formed by those limbs, is equally important, and perhaps most important is in tetralogy are the septoparietal trabeculations, because it is these trabeculations which stream from the anterior margin of the septomarginal trabeculation which produce the muscular hypertrophy which, together with the deviated outlet septum, is the hallmark of tetralogy. And here you see those various features in another heart that I've sliced to replicate the echocardiographic subcostal oblique view. So coming across the tricuspid valve, the overriding aorta, up to the pulmonary valve, we can nicely see the pulmonary trunk running back and dividing into its right and left pulmonary arterial branches. And now very beautifully you can see how the ventricular infundibular fold is indeed the inner heart curvature. If you go through here, you come across the transverse sinus. A little more laterally, the branch of the right coronary artery will be lying in there. Here you see a freestanding outlet septum, confluent with the freestanding subpulmonary infundibulum. Note the offsetting of the attachments of the pulmonary valve relative to those of the aortic valve. Here are the hypertrophied septoparietal trabeculations, and you see that the narrowing of the subpulmonary outlet is a squeeze between muscular outlet and septoparietal trabeculations. And here is the septomarginal trabeculation extending down towards the body of the ventricle, with the crest of the ventricular septum formed by its posterior and anterior limbs. If we look at the extent of these various muscle bundles, we can find the variation in structure of the hearts which are grouped together to tetralogy because of the combination of the anterocephalad deviation of the outlet septum together with the subpulmonary stenosis. And there is variability in all of these features. Most of the ventricular septal defects, 4/5, will have fibrous continuity between the leaflets of the aortic valve and the tricuspid valve. And so these have perimembranous defects together with malalignment of the outlet septum and overriding of the aortic valve. In the majority you will find a remnant of the interventricular component of the membranous septum, the so-called membranous flap. The conduction tissue obviously will be running postero-inferiorly, directly related to membranous flap. In 1/5 of cases, a small minority, there is a muscular posterior-inferior rim giving a complete border to the ventricular septal defect when viewed from the right ventricle. As in the doubly committed defect, this is produced by fusion of the posterior limb of the septomarginal trabeculation with the ventricular infundibular fold. But distinguishing this heart from the doubly committed defect is the extensive and hypertrophied outlet septum producing muscular subpulmonary stenosis. So here we have tetralogy with a muscular malalignment defect. This muscular rim will protect the conduction axis. There are hearts which do have fibrous continuity between the leaflets of the overriding aortic valve and the narrowed pulmonary valve. In my notes, I make the comment that these hearts have a relationship to tetralogy of Fallot, because clearly in these hearts there is absence of the muscular outlet septum and also of the muscular subpulmonary infundibulum. So are they strictly tetralogy? You pays your money, you takes your choice. I think most people would probably put them in the grouping of tetralogy, but remember they are a special group because the muscular outlet septum is lacking. There is variability in the extent of the muscular subpulmonary obstruction. In this heart, extensive hypertrophy and overgrowth of the outlet septum, together with septoparietal trabeculations. Note these freestanding trabeculations that can be easily removed. But there is spectrum where the outlet septum gets smaller and smaller until we end up with the heart I've just shown you, with fibrous continuity between the aortic and pulmonary valves. And it is that spectrum, more than anything, which makes it justifiable to put the heart with doubly committed group into grouping of tetralogy of Fallot. In others, you may find apical shelves dividing the right ventricle, and two-chambered right ventricle can coexist with tetralogy. A major bone of contention is the relationship between the ventriculo-arterial connection and tetralogy of Fallot. If you look at enough cases, you will find the majority in which only about 1/3 of the aortic valve is connected within the right ventricle. So the aorta predominantly coming out of the left ventricle. But as I say, if you look at a large number, you will find a proportion in which 9/10, or as in this heart, the entirety of the aortic valve is connected to the right ventricle. There is anterocephalad deviation of the outlet septum. There is muscular subpulmonary stenosis. I have no problem in describing this as tetralogy with a double outlet ventriculo-arterial connection, but I know for many that is an impossibility. Again, it depends upon the definitions you use. I simply define the ventriculo-arterial connections according to the way that the arterial trunks are joined to the ventricles, and in this heart, to my eye, there can be no doubt that both the aorta and the pulmonary trunk spring exclusively from the right ventricle. And if I don't call it double outlet, then I don't know what else I can call it. The associated malformations are important and should always be looked for, particularly anomalous arrangement of the coronary arteries. I've chosen to illustrate to you one particularly important one, so-called absence of the leaflets of the pulmonary valve. Usually there are rudiments present. This does not always exist with tetralogy, but mostly it does. And the problem is the dilation of the pulmonary arteries, which produces bronchial compression. And, as I've already emphasized, a particularly important grouping, probably the most important associated malformation, atresia instead of stenosis. We can find all the variation in this entity that we find in tetralogy with pulmonary stenosis, but together with these important variations in source of pulmonary arterial supply. Here I've chosen the two most important sources. There are other ones, but in probably 90 to 95% of cases, the source of supply will either be through the arterial duct or through these crucial vessels, systemic to pulmonary lateral arteries. There is no question that these hearts are tetralogy with pulmonary stenosis, pulmonary atresia rather, and in a small proportion you will even find atretic imperforate pulmonary valves with obvious anterocephalad deviation of the muscular outlet septum. In the majority of cases, however, the outflow atresia is muscular rather than valvar, but still with the deviated outlet septum, they fall into the ballpark of tetralogy. The most important variation, nonetheless, is the arrangement of pulmonary arteries. When there is an arterial duct feeding the pulmonary arteries, then always, in my experience, the pulmonary arteries have fed all the bronchopulmonary segments, though on occasions they may be non-confluent with bilateral ducts. Here I've pulled forward the aorta so you can see the pulmonary trunk, you can see the rather thread-like duct which has a tendency to close, and you see the pulmonary arteries feeding all the bronchopulmonary segments. This is the easier group to treat at surgery. The problematic ones are those in which, when you look at the descending aorta, and here we're looking at the heart from behind, so this is the left lung, here is the heart, here is the descending aorta. The most problematic ones are those where the pulmonary arterial supply comes not from the heart, not from the arterial duct, but from the systemic to pulmonary collateral arteries, usually 2 to 5 in number, and these anastomose with intrapericardial pulmonary arteries in the majority of cases. So the problem in these is determining precisely how much of the supply comes through the collateral arteries, how much comes through the pulmonary arteries themselves. Try to achieve unifocalization so the conduit can be passed from the right ventricle to the intrapericardial pulmonary arteries. These are the greatest challenge to you as surgeons. Now, thus far, we've considered only hearts in which the segmental combinations have been normal. We now turn our attention to a heart which exists not because of disordered anatomy, although there is disordered anatomy, as we will see, but a heart which exists because of an abnormal connection of the cardiac segments. And this is the heart that you may simply call TGA, transposition. We like to call it complete transposition, and it is the combination of these segmental arrangements. Either usual or mirror-imaged atriums, the atriums connected to the appropriate ventricles, the ventricles connected to inappropriate arterial trunks. So the blood goes from right atrium to right ventricle to aorta, left atrium to left ventricle to pulmonary trunk. The circuits are in parallel rather than in series. And clearly this can exist in the usual arrangement in 98% of cases, and in a very small proportion in a total mirror image format where everything is back to front. Right atrium, the right ventricle, and the aorta are all left-sided. There are various anatomic patterns. When the ventricular septum is intact or nearly so, then this is usually called simple transposition. The complex forms are those with ventricular septal defect or ventricular septal defect together with subpulmonary obstruction, although obviously subpulmonary obstruction can also exist when there is an intact ventricular septum. When you group them in this fashion, do remember that there are other very important associated malformations. The variable features within all of these groups, having chosen to group the hearts together according to their segmental combinations, are the relationships between the aorta and the pulmonary trunks, infundibular morphology. Probably 85% of hearts have, with usual arrangement, the aorta anterior and to the right of the pulmonary trunk, but do not be surprised if on occasion you are confronted in the operating room by a heart such as this. This heart has usual atrial arrangement. Here is the right-sided right atrium. The right atrium connects to the right ventricle. This again is one of Dr. Wilcox's pictures. And as you can see, unequivocally, the aorta is to the left of the pulmonary pulmonary trunk, that the anterior aorta is springing from the right ventricle. This heart, with a left-sided aorta, has ordinary complete transposition. It is the segmental combinations that produce entity, not the relationships of the arterial trunks. As we will see, it is those relationships that are an important variable. And indeed, exceedingly rarely you may come across cases like this. The cuts up the ventricles tell you that the right ventricle leads to the aorta, the left ventricle leads to the pulmonary trunk. There is complete transposition, but you will also notice that in this heart, the aorta is posterior and right-sided relative to the pulmonary trunk, normal relations. So even on occasions when the arterial trunks are normally related, the segmental combinations still produce complete transposition. Arterial relationships and infundibular morphology are variables. It is the segmental combinations which produce the anomaly. As you look at this picture, which shows you the variability in the ventricular septal defect, I hope you will note the similarity with the description of the ventricular septal defect when isolated, because as I emphasized to you, the method of describing the ventricular septal defect holds equally good when the hearts themselves have other malformations. So all of the variability we saw for the regular heart can be found in complete transposition. The majority of hearts will again be perimembranous. The malalignment defects are particularly important in the setting of complete transposition, but all of these others can exist, although doubly committed defects are particularly rare. So here is a relatively small perimembranous defect. You will appreciate, of course, that in complete transposition, because it is now the pulmonary trunk that is springing from the left ventricle, the anatomic feature we look for is now tricuspid to pulmonary continuity in the posterior inferior margin of the defect. We recognize muscular inlet defects, exactly the same connotations for the conduction axis. It runs antero-superior relative to the muscular defect. But the most frequent ventricular septal defect is the one that has malalignment between the muscular outlet septum and the crest of the ventricular septum. And note again the limbs of the septal marginal trabeculation, which are cradling the crest of the ventricular septal defect. Note also that the posterior limb of the septal marginal trabeculation fuses with the ventricular infundibular fold. So once more, this muscle bundle found posterior-inferiorly protects the conduction axis. Exactly the same rules guide you to the structure of the ventricular septal defect. Subpulmonary obstruction can take various guises, and these are the entities in hearts with concordant ventricular arterial connections that would produce subaortic obstruction. So deviation of the outlet septum in complete transposition will produce subpulmonary obstruction, because of course it is now the pulmonary trunk that is springing from the left ventricle. But all of these others are important, particularly dynamic obstruction, which will reverse in most instances when left ventricular pressure overwhelms right ventricular pressure, for example after an arterial switch. These are more concerning in the setting of a switch, the fibrous shelf, tissue tags, anomalous attachment of the AV valves, because after a switch they would leave subaortic overt obstruction, and that would not be good news. So here are the various entities: the deviated septum, tissue tags, dynamic obstruction, often combined with a fibrous diaphragm or shelf, anomalous attachments of the AV valves. All of these can coexist with valvar stenosis. Valvar stenosis in itself does rarely exist, as does a bicuspid pulmonary valve. This can exist in isolation and is not a contraindication to an arterial switch. This arrangement is relatively frequent and is particularly important. Here again we're looking at it from the left ventricle. Here is the mitral valve. Here is the overriding aorta. And here is the narrowed subpulmonary outflow tract, narrowed by the posteriorly deviated outlet septum. This arrangement is important, of course, because it is possible to connect the aorta to the left ventricle through this ventricular septal defect, tie off the pulmonary trunk and put a conduit from right ventricle to pulmonary arteries, and that, of course, is the Rastelli procedure. And so this is a particularly important variant to recognize of subpulmonary stenosis. This is a much nicer variant for the anatomist to recognize. We're looking at the left ventricle of a heart with complete transposition, and this is a little tissue tag that I've pushed through the ventricular septal defect, and you see that it's attached by cords around the margin of the defect. You can either remove this and simply patch the defect. There are no nasty things within there, and although on occasions the tissue tag itself has been used as the patch close the defect. No question, however, that nowadays the most important feature of complete transposition is the arrangement of the coronary arteries. Once more, we get into the problem of how to describe and categorize the arrangement of the coronary arteries. There are the most horrendous codifications that have been suggested for classifying these coronary arterial patterns. I would defy any of you to remember the Sheher and Pudu combination with 5A, B, C, 9A, D, and what have you. As I say, I dislike alphanumeric codification, so I admit my bias there. But I think that to take note of all these things, description is far better than classification. So I think it's better to describe firstly the origin of the coronary arteries from the aorta, then take note of the course of the three main branches, say whether these branches are retropulmonary or antro-aortic. Look particularly for this arrangement, which now is still the one potential contraindication for an arterial switch, and do not ignore the crucial artery to the sinus node. We can also take advantage of some pretty nigh-on constant rules. This is the short axis of a heart with complete transposition. We're looking at it from above. So this is the left side, this is the right side, mitral valve, tricuspid valve, pulmonary trunk, and aorta. I've sliced off the aorta and the pulmonary trunk, and you can see that two of the sinuses of the aorta are adjacent to two of the sinuses of the pulmonary trunk. And this is a very regular rule. Although there may be a degree of commissural mismatch, in the greater majority of cases, commissures face each other. Furthermore, almost without exception, there are one or two cases described where coronary arteries arise from the non-facing sinus, but I have never seen one in complete transposition. In all the cases I have seen, probably 300 or more now, the coronary arteries arise from the two sinuses of the aorta, which are adjacent to the pulmonary trunk. And we can take advantage of that fact for describing the coronary arterial origins. We must remember, however, that the relationships between the arterial trunks is multiply variable. If you look at enough hearts, sometime and in some place, you will come across a heart in which the aorta is posterior and to the right, anterior and to the right, anterior and to the left, even directly left and side by side. If you're going to describe these sinuses according to their position in space, you're going to have a different convention for each of these variations. It is much better, I believe, to recognize that this is a rotational variation and that relative to each other, the arterial sinuses bear a constant relationship. And that was the proposal put forward by the group from Leiden for naming the aortic sinuses. Why do I call this the Leiden Convention? I call it the Leiden Convention because it's much easier to say Leiden than it is to say Gettenberger Groot and Gracheburg, who are the people who popularized this convention. So they pointed out that these sinuses do rotate around one another, and they called them sinus number 1 and sinus number 2. Now at first I was not taken by sinus 1 and sinus 2, and I showed you this picture yesterday for the normal heart. I preferred to have a little mannequin looking at the pulmonary trunk, and then one of the sinuses was to his left hand, the other to his right hand. And we discussed yesterday how in the normal heart the left-hand sinus gives rise to the left coronary artery, the right-hand sinus to the right coronary artery. So it was relatively easy, I thought, in complete transposition, to think of the little surgeon again standing in the non-facing sinus, looking towards the pulmonary trunk, and then again the sinus to his right hand was number 1, that to his left hand was number 2. The problem, however, in complete transposition is that in the majority of cases this right-hand sinus gives rise to the left coronary artery, and that seemed to bother a lot of my colleagues. So I think it was Dr. Joseph Amato, now working here in Chicago, who first suggested that you could then place the little surgeon in the pulmonary trunk, which would become the aorta, if he then looked towards the aorta, which after the switch would be the pulmonary trunk. His left hand would then be on the left coronary artery in the majority of cases. And lots of surgeons have subsequently adopted this principle. I'm not entirely sure that it always works, so I've now gone back to sinus 1 and sinus 2, and I think most of you who do any degree of arterial surgery will be aware of which is sinus 1 and which is sinus 2. And if you look at series, you will find that in over 80% of hearts, the majority fall into these two patterns. 70% have the regular pattern, circumflex and anterior descending from sinus 1, right coronary artery from 2. The second commonest pattern is where the circumflex artery also comes from sinus 2, but takes a retropulmonary course. But what Quackenbuhr and Gitten de Groot showed was that if you look at enough hearts, at some time or at some place, you will come upon one of these 8 possible variables, which are the only ones that can exist when you recognize the 2 sinuses and 3 coronary arteries. So those are the possibilities. This unequivocally is the most important variable of which you as surgeons now need to be aware. If we could put down the lights a little bit. I maintained I had never seen an intramural coronary artery. My friend and colleague Xu Yen Ho then pointed out that I may never have recognized it, but in fact I had a case in my own files, and this was lying there, and if you look very carefully, this is a pulmonary trunk which is much larger than the aorta. You will appreciate that the vessels are side by side. At first sight it looks as though the anterior descending and here the right coronary artery are originating from sinus number 1, but if you look very carefully, you see that in fact they run through the wall of the aorta, they cross the commissure, and they originate from sinus number 2 together with the retropulmonary circumflex. So this is the most important variant, an intramural course of here the anterior interventricular and the right coronary arteries, so a single sinus origin from sinus number 2 of all 3 coronary arteries. And also, do not forget the artery to sinus node. Finally, just a few words to complete a rapid walk through congenital heart malformations with the Fontan procedure. You are all well aware that in fact you can use the Fontan procedure for any heart, because it does not depend upon the anatomy. It depends much more upon the prevailing hemodynamics. But probably it is still the case that the commonest lesions for which it is used are tricuspid atresia and double inlet left ventricle. And these 2 entities have very much in common. Tricuspid atresia is often thought to represent an imperforate tricuspid valve. In fact, that is exceedingly rare. Less than 10% of cases in autopsy series have imperforate valves. When they do, they usually have coexisting Stein's malformation. The essence of the garden variety of tricuspid atresia is complete absence of the right atrioventricular connection. And that has a very important effect upon the ventricular mass because it produces big left ventricle and small right ventricle. The small right ventricle is not only hypoplastic, it's also incomplete because it lacks its inlet component because of the absence of the right AV connection. And this is why I find it most valuable to analyze ventricles in terms of inlet, outlet, and apical part, because only when you do it in that way can you recognize absence of the inlet. Another important feature, the variability in ventricular arterial connections. The aorta can arise from the right ventricle, left ventricle, or indeed both arteries can arise from either from right or left. Very rarely there can become an arterial trunk. Now do not let me give you the idea that imperforate valves never exist. Indeed they do. Here is a beautiful example of an imperforate tricuspid valve. Here is the mitral valve leading to the left ventricle. This imperforate tricuspid valve in fact overrode the ventricular septum, so it was intermediate between a heart with double inlet and one with concordant atrioventricular connections. You can see that this valve probably was stenotic and eventually closed. So they do exist, but they are as rare as hen's teeth. By far the commonest pattern of tricuspid atresia is the complete absence of the right atrioventricular connection. Here is the inferior caval vein, superior caval vein. This is the right atrial appendage, the pectinate muscle surrounding what ought to be a right atrioventricular junction, but there is no right atrioventricular junction. Instead, there is a dimple. Dimple is often thought to represent the imperforate tricuspid valve. In fact, the dimple is the atrioventricular component of the membranous septum. This is a four-chamber section through a heart with tricuspid atresia, and it shows you exquisitely the absent atrioventricular connection with the right coronary artery in the fibrofatty groove separating the floor of the right atrium from ventricular mass. The dimple is pointing to the subaortic outflow tract because tricuspid atresia is trying to be double inlet left ventricle. And that is the connection between these two entities. It is also the case that because the right atrioventricular connection is absent, the right ventricle has only a hypoplastic apical component and an outlet, in this instance the pulmonary trunk. So double inlet left ventricle is very comparable to tricuspid atresia because it also has big left and small right ventricle, and the right ventricle is incomplete and rudimentary because again it lacks its inlet, in this instance because both inlets are going to the left ventricle. As in tricuspid atresia, the ventricular septal defect is the outlet, that rudimentary and incomplete right ventricle, and there is exactly the same variability in ventricular arterial connections. So the essence of double inlet left ventricle, as you see in this four-chamber connection section, is that both segments of atrial myocardium are connected to the same ventricle. Because of its fine crisscrossing apical trabeculations, we know that this is a left ventricle. Double inlet left ventricle, however, is not a single ventricle because sitting anterosuperiorly within the ventricular mass is the rudiment of the right ventricle. And again, you can see the advantage now of analyzing the right ventricle in terms of three components. We know the inlet is connected to the dominant left ventricle, so the right ventricle has an apical component of right ventricular morphology, an outlet component in this heart supporting the pulmonary trunk with a restrictive ventricular septal defect. What is important in this analysis is that we know that this is the remnant of the apical trabecular septum, and therefore that it carries the conduction system. So, when we have big left ventricle and small right ventricle, be it tricuspid atresia or double inlet left ventricle, the course of the conduction axis is comparable. It's posterior inferior to the ventricular septal defect when viewed from the right ventricle. If the aorta springs from the right ventricle and there is a restricted ventricular septal defect, then septal excision can safely be performed moving towards the left descending artery. There is an anterior node in double inlet left ventricle, but in tricuspid atresia, because the right AV connection is absent, there is a much larger node that is directly related to the dimple. That, however, is relatively unimportant. You as surgeons in Fontan procedure are more likely to be called upon to enlarge the ventricular septal defect. Here is the view of a highly restrictive ventricular septal defect with the aorta springing from this rudimentary and incomplete right ventricle. It might be tricuspid atresia, it might be double inlet, it doesn't matter. You can enlarge the defect by taking a wedge of tissue closest to the left margin of the heart. And that is because whether the right ventricle is found in rightward position, this is the margin that can be taken away. Conduction axis is posterior inferior. If the rudimentary ventricle is left-sided, there is simply a longer bundle which swings in front of the pulmonary trunk, but still the margin that can be excised is that closest to the leftward part of the ventricular mass.
I'm going to start with ventricular septal defect, go to tetralogy, and then go to transposition. There are a number of things here that I want to point out, that there are some concepts here, and I'll tell you what they are as time goes by, okay? I'll also tell you when you need to write something down, when you don't need to write something down. So let's get started then. This is one of my favorite topics, ventricular septal defect. Seemingly everyone, when they say, oh, it's just an ASD or a VSD, it's really not just a VSD. VSDs are rather complicated issues, and they're very interesting to dissect out in terms of not pathophysiology, but also anatomy as well. What it is an opening in the interventricular septum. That's pretty clear. And it's the most commonly recognized congenital defect. 1,000 live births, 20% in all forms of congenital disease, which means that it's part of truncus, it's part of tetralogy, it's part of SD, and so on. And 50%, considering when you consider isolated VSDs and VSDs with other lesions, it's 50%. So you see it a lot. This is not important. I would not write any of this down. I wouldn't commit it to memory. Those of you who were interested are from the University of Virginia. Dr. Muller did the first pulmonary artery band in 1952. These fellows are rather important. Well, Lily Hyde did it in cross circulation in 1954. Some of you may not even have been born then. I was 8 years old here. Kirkland and Sloan and others here have refined it to the point of view now where it's a safe procedure to do. Don't write any of this down. This is, you can find in any textbook. It's irrelevant to what you really care about in terms of answering the questions right on the examination. It's of some interest. If you want, you can read it. Now, this is what I want to point out to you, that there are, in most situations, 4 types of ventricular septal defects. Unfortunately for you, there are 2 or 3 different kinds of classifications. I'm going to tell you what they are. This is the first one, and unfortunately it says A, B, C, D. That's not what it is. It's usually written down as Roman numeral. Roman numeral 1 has a lot of synonyms for this one, okay? This is called subarterial, it's called conal, it's called type 1, and it's right over here, right underneath the pulmonary valve and associated with the aortic valve. Here, the pulmonary valve, there's the aortic valve. It's high up, and it's also called an outflow VSD. The second type is a paramembranous. Everyone talks it, whether it's perimembranous or paramembranous, depending upon what your knowledge of Latin is. And I don't think it makes a big difference, but those of you from Boston will call it paramembranous. paramembranous because von Prague is there, and those of us here call it paramembranous. Those of you want to call it a perimembranous, it's to you. It's over here. It's sort of a near the tricuspid valve and underneath the aortic valve. Here is the so-called, and that's type 2. This is the so-called inlet VSD, also called a AV canal type VSD, and right behind the tricuspid valve, it's a little bit lower down in the septum. And of course, the last one is a muscular VSD, and that's easy. That's what you see. Here is another way of looking at it. Inlet, outlet, muscular defects can be in different areas. This is not used much. Here is one where one could classify it as the inlet and the outlet, and then in the muscular portion here. Then all of a sudden you have a VSD that is in the paramembranous area but goes out to the outlet, and that's called a paramembranous VSD with an outlet extension. Then you could have a paramembranous VSD with an inlet extension. You can classify anything you want. But if you can remember 4 different types, and if you can remember a paramembranous VSD with a possible outlet extension or inlet extension, I think you got it. I think you got it. Now, this is a chest X-ray with a lot of blood going to the lungs. It's easy. It's not a big issue. Pathophysiology is rather simple, if you will. There's a left to right shunt. Remember, it's a left to right shunt. And if a left to right shunt is 2 to 1, it's categorized. It's called a left to right shunt, but it's categorized from the right to left. What do I mean by that? It's 2 to 1. That means it's twice the amount of blood flow going to the pulmonary artery than to the aorta, right? So then you're putting the right side flow first before the left-sided flow. Yet it's called a left-right shunt. Is that pretty clear? I think that's pretty clear. It's not my fault. That's just the way it is. So it's a left to right shunt, and then you call it the pulmonary side. And then that keeps going when you talk about tetralogy, because your tetralogy, you talk about a 0.7 to 1 left to right shunt, right? Which obviously is a right-left shunt. But so they keep, at least they keep it consistent. The physiology of VSD is interesting. It turns out that 2 years is a big issue. What happens is that the child is born with a large VSD and there's no murmur. And then no one picks any murmur up. The patient goes home. The family thinks they've got a great kid. And then at 2 months of age, the child goes to the pediatrician, and then you hear this big, huge murmur. And, ma'am, your child has got a ventricular septal defect. Well, why didn't they tell me that 2 months ago? You know, this is the same kind of thing. And, of course, it's important for us to realize, because the reason why they didn't tell them is because there's no murmur, and the reason why there was no murmur is because of the pulmonary hypertension of the newborn, right? We're all born that way. We're all born, whether we have a VSD or not, with equal pressures in the right ventricle and the left ventricle, and they'll become important when I talk about the arterial switch operation. So what happens is that the pulmonary vascular resistance falls, right? The murmur starts to be heard, left to right shunt occurs, and a couple of things can happen. One, the left to right can be so bad the patient dies, or gets into congestive heart failure, or is seen by a physician and he gets put on DIG and gets a little bit better. Or it's smaller and then all of a sudden it closes. Or it gets ignored, and then after 2 years of age, irreversible pulmonary hypertension occurs, and then the child will get better with the VSD open. The murmur will go away for a little while, and then as time goes by, the pulmonary vascular resistance will get worse and worse. The shunt will go from left to right to left. Then this patient has a so-called Eisenberg's disease, resulting in cyanosis and eventual death. I'll come back to this about when we close VSDs, but the reason I bring up 2 years is because 2 years, more or less, is a time when irreversible pulmonary hypertension starts to occur. You like to close the ventricular septal defect if it's large enough before that time. If it's large enough is a little bit of a controversy at the present time. For your purposes, large enough is 2 to 1 shunt. Now, in my practice, large enough is 1.5 to 1 shunt. But that's a little controversial. You're safe to say if the child's got a 2 to 1 shunt, it's very safe to close the ventricular septal defect. Okay? Natural history I just really went over. Let me go back to that. Natural history, besides Eisenberg's disease, there are a couple other things that can happen. Most VSDs are restrictive, and they close in the first year of life. Okay, so if somebody is presenting in front of you and giving you an oral examination, and they say, well, I've got a ventricular septal defect and the patient is 3 months old, what do you do with that patient? That's a trick question. You say, well, you need more information. If it's a large VSD and the patient's in trouble and have congestive heart failure and you can't get him out, we'll close the VSD. But if not, then we'll treat him medically for a little while, because most VSDs close and you don't have to do surgery. Everybody wants to find you, as you know, general surgery. Everybody wants to find if you're a safe surgeon. So be a safe surgeon, okay? Don't not operate, but be a surgeon. Ask some questions and say, well, is this what you want me to do or not? And so the point is that most VSDs close by themselves. But the other thing is that they will rarely close after 2 years, and certainly after 5 years they rarely close. The mechanism of closure, this is of some interest, is that the tricuspid tissue gets involved in there and it can close it off, and sometimes the aortic valve tissue can come down into the VSD and close it that way. If that happens, that can be a problem because that results in aortic insufficiency. I'll get to that in a little bit. Large VSDs result in congestive heart failure, high pulmonary vascular resistance, and these have to be done early on, especially if the patient has symptoms. The diagnosis is pretty obvious. There's a murmur, there's a large second heart sound with the pulmonary valve closing, and chest x-ray and so on, echo, catheterization. Pay attention to these next 4 or 5 slides. The reason I say that is when I took this examination, there were no echoes on my examination. I won't tell you how many years ago. There will be plenty of echoes in your exam. Plenty. Okay? That, if we operate on echoes now. So this is, you're going to be expected to know this. Okay? Put this to memory. I'll leave it here for a little bit so you can stop writing. You have to memorize this because you have to recognize it during an examination. This is a long-axis view, and here is the aorta. Here's the left atrium, and if you notice, there's a ventricular septal defect. When the ventricular septal defect is near the aortic valve or below it, it's either going to be an it's going to be a conal VSD or a paramembranous VSD. This is not the view they'll give you for a conal VSD. This is the view that they'll give you for a paramembranous VSD. There it is. Okay? Left ventricle, right ventricle, here's VSD, usually right below the aortic valve. Take that back. Take it back. That's why it's so confusing. It confused even me. This is a conal VSD because it's right below the aortic valve. All right? This is what they'll give you. This is a conal VSD, the type 1, right below the aortic valve. And you can see sometimes if this valve comes below and below here, it'll block off this VSD here and cause aortic insufficiency. This is a conal VSD. I'm sorry, I misspoke. This is an aorta, left atrium, left ventricle. This is a so-called paramembranous VSD, and you see this? That's a tricuspid valve. If you see an arrow coming here with the tricuspid valve, this is a so-called tricuspid pouch, and this is a paramembranous VSD. You've got to see the hole, there's the hole, and then you've got to see what relationship it is to the tricuspid valve and what relationship it is to the aortic valve. Okay. This is a four-chamber view. Anytime you see a four-chamber view, they want to emphasize the tricuspid valve and the mitral valve. If there's a VSD here, it's got to be associated with the tricuspid and the mitral valve in this section over here. Ergo, this is a type 3 or a canal type of VSD. I wrote a question. This will be on one of your examinations. Whether you do it, whether it's in your year or the year after, this will be on. That's a type 3 AV canal type of ventricular septal defect. This is easy. Right atrium, left atrium. Here's the intraventricular septum, LV, RV. I'll give you this, by the way, in the examination, but you just got to find out where the hole is and call it the right thing. This is a muscular VSD. Okay? These are a little easier. These are angiograms. You probably won't see very many of these. Here's the aorta. Here's the pulmonary artery. You notice that the ventricular septal defect is very, very high in the conal septum, and this is a conal VSD. Here's the aortic valve. Here's the left ventricle, and here is a big pouch. If you see a big pouch like that, it can be nothing else except a paramembranous VSD with a tricuspid pouch. And this pouch is trying to close this VSD, but it didn't because there's an escape here of contrast material here and here. Okay? This is another angiogram showing a tricuspid pouch, but look, it's coming out this way. But what but although this may look like a tricuspid pouch, look at this. You can just about see this. This is the aortic cusp, which is prolapsing into this ventricular septal defect and causing obstruction of ventricular septal defect. In reality, if you bring the cusp back, this is a very large ventricular septal defect. Okay, write this down. If you see an examination question and it says which cusp is more associated with a conal ventricular septal defect, it's the right coronary cusp, most likely. Which aortic cusp is associated with a paramembranous is a non-coronary cusp. This is notice the ventricular septal defect is further down in the septum. Here's the aortic valve. This is the sinotubular junction right here. Here's the valve, and it's further down, and this is a type 3 or a AV canal type of VSD. This is clearly easy. Here is the muscular VSD. It's quite large, and that's easy enough to recognize. You all know what that is, right? Swiss cheese type of VSD. And if I may make a point here, this is probably one of the few indications for pulmonary artery band now in any institution. No one would dream of trying to close its ventricular septal defect. The thing to do is to do a pulmonary artery band there. Well, the medical management is pursuant to the pathophysiology, and what that means is it's pursuant to what kind of symptoms the patient has. Digoxin, diuretics, and captopril. Everybody know the way captopril works? Who does not know the way captopril works in this situation? Come on. You all know. Decreases the peripheral vascular resistance, thereby decreasing the left to right shunt. Yes? That's pretty good. Nutrition support, antibiotic therapy, assisted ventilation, and pulmonary vasodilators as a for surgery. What does that mean? It means that if you have an older patient who's 20 years old, or 18 or 15, who you worry about there's a fixed pulmonary vascular resistance, take them to the cath lab and there's a 1-to-1 shunt with a huge VSD, then if you give them pulmonary vasodilators and they respond to that and they increase their shunt from 1-to-1 to 2-to-1, that's a pretty safe bet that that patient will do okay and close that VSD. So that's why you'd want to use pulmonary vasodilators to check that. Well, let's talk about when to close the VSDs. VSDs are categorized in general as small or large. We're not talking about types now, anatomic types, we're talking about physiologic types, okay? Remember, there are anatomic types, and that's important as the surgeon. There are physiologic types, that's important as a diagnostician referring the patient to surgery. Now let's talk about physiologic types. They're either large or small. And if they're large, they're manifested in the following way. Infants with severe congestive heart failure, anytime during the first 3 months, if they have this, you close them. If the infants respond to diuretics and so on with a large ventricular septal defect, you watch them till about 6 months, and especially the QP-QS ratio is 2-to-1, and you can close the ventricular septal defect at that time. If they're old patients with large VSDs but are not candidates, that is to say if the pulmonary vascular resistance is greater than 8 units and there's a small QP-QS ratio and there's no response to vasodilators, these patients may not or made poorly with a ventricular septal defect closure. Okay? You'll be asked this question. When is it improper to close a ventricular septal defect in an 18-year-old or 20-year-old? What they'll do, the reason why they'll ask this question is they'll know most of you are going to be doing adult surgery. And so if you're doing adult heart surgery, occasionally you'll get a patient with a VSD. So, well, I know how to close that. Not a problem. What they want you to do is to know that some patients with large VSDs in adulthood may not do well when you close their VSDs. And that is the point that they want to get across. Can you make that decision correctly? And that decision is made on the pulmonary vascular resistance. Usually 8 units is about right. And then if there's no response to vasodilators. Patients with small VSDs. This is a little interesting. When do you close ventricular septal defect? Patients who have small VSDs. Well, aortic valve prolapse, aortic insufficiency, direct indication. No matter what the QP-QS ratio is, direct indication. Endocarditis. Where does endocarditis occur in a patient with a ventricular septal defect? Come on, raise your hand. Yes, what is it? The width, where's jet head? Tricuspid valve. What leaflet? Septal leaflet. Remember that. Septal leaflet. And then also remember in general that endocarditis occurs where the jet hits whatever it's hitting. For instance, in a PDA, the endocarditis will occur in the pulmonary artery, not in the aorta. It occurs where the jet is. For coarctation of the aorta, where does the endocarditis occur? Post-jet in the descending aorta. Okay? Remember that. And that's a simple thing to remember, and it holds true in most situations. Even if the QP-QS ratio is less than 2 to 1, there are some patients that you will do, you'll close a ventricular septal defect on, and that is all patients with conal ventricular septal defects will have their VS closed. All of them. Okay? And the reason is because these patients have a propensity to develop aortic insufficiency. You're better off closing the VSD and dealing with that is to say, stop the progressive aortic insufficiency than you are leaving the VSD and doing aortic valve replacement later on. Okay? On contact, on site, all conal VSDs with a good time period, which are conal, ought to be closed. And it's because of the aortic prolapse and resultant aortic insufficiency. And it depends on the institution. We close them less than 2 to 1. It's about 1.5 to 1. We've had 141 patients, no deaths, no heart block, no residual VSDs. So I think we're heading in the direction of closing VSDs more towards 1.5. But for your purposes, 2 is a pretty good number to remember. That is to say 2 to 1 shunt. Patient selection, like I said, patients with conal VSDs, early surgical repair. Operative approach. Would anyone close a ventricular septal defect through the right ventricle? Would anyone do that? Yes, you would? It's not a bad way, I guess. It's been done a long time. But I wouldn't do it that way. How would you close a VSD? Through the right atrium? Yes? Everyone would close a VSD through the right atrium. And that's the preferred way of closing it, through the right atrium. One could also do it through the pulmonary artery, especially if it's a conal VSD. You can do it through the pulmonary artery. That's a pretty good approach. You can do it through a transaortic approach if you're doing a switch and there's a VSD up there which is right below the aortic valve. You can do the right ventricle and left ventricle, and I'll show you under what circumstance to do that. You'd close a VSD to the right ventricle if you're doing a truncus, right? But not just for a VSD. You'd always do that through the atrium. This is just exposure. Notice that the atrium, the incision is made here to the medial portion of the infravena cava catheter, because then you could see the entire tricuspid valve. And what are the considerations? How would you go about doing this? You might get a question on this. Bicaval cannulation, atrial cardiopulmonary bypass, hypothermia, depending upon how you do this, left ventricular vent, cross-clamp cardioplegia, interrupt versus running suture technique. It doesn't matter whether you do it interrupted or running suture technique. It's important when you're standing there giving your answer that you give the answer. Okay? Doesn't matter what you use. In my hands, I use interrupted technique and sometimes use running. That's okay. If you use interrupted, say that you do that. Doesn't matter what you use. Just say in your hands. And if the person says, well, you know, I don't think that's a good idea, so, well, it may not be good for you, it's good for me. I wouldn't. I'd say it. I'd say it. Tricuspid valve incision. Sometimes you have to incise the tricuspid valve. I'll give you an example of that. Here's the tricuspid pouch, what it looks like in artist's representation. This is the septal leaflet. This is the leaflet that gets infected, remember. And so in order sometimes to see it, you have to make an incision. And there's the incision. You can see the VSD. Now you can close it. You know, closing a VSD is not magic, right? You have to see it. I mean, if you've been somewhere and the surgeon helping you or who's doing it hasn't been able to show it to you, you say, what the hell's going on here? I have to see it. You have to see to put the VSD sutures in. So this is one way of seeing it. And you put plegited sutures. This is a rather tedious technique. Those of you who train with me know that I always say that, tedious technique, but it works and the VSD gets closed. This is a conal VSD looking through the pulmonary artery now, okay? Pulmonary artery doesn't beat, so you can cut it. And there's the prolapse right cusp of the aortic valve, right? Remember what I said? It's going to be the right cusp. There it is. Here's the septum. You put the you took interrupted pledgeted sutures around the area here, put it through a patch, and this is how it works. Sometimes you put it in the pulmonary cusp right here. Notice that the pulmonary cusp and the aortic cusp are very, very close together, so you err on the pulmonary side. And that's what it looks like after the operation. Sometimes you want to do it through the aorta, and it can be done much more difficultly, but it can be done this way. If ever I do this, I usually do it. I'm doing a switch VSD because then I can see the VSD this way. Another way of doing it is through the right ventricle. I show this to you because some of you have been in a place where they do it through the right ventricle. It's okay. You're in the minority, but you know you're better off saying, even though they did do it in your place through the ventricle, you're better off saying they did it through the right lie. So this is not a good situation. This is an interesting approach because at the apex of the left ventricle, and I asked the artist to do this especially because this is the only way that I would make a left ventriculotomy, and that is at the apex. Never do it over here. Never, 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 never. If you do it at the apex. This is contraindicated. I wouldn't do this anymore either. I will through the right atrium. I usually be able to find it. And if people ask you how you find it, you can say that you cut the trabeculations. And if you cut the trabeculations of the right ventricle, you can usually see this large muscular ventriculoseptal defect. Now, surgical considerations. Pulmonary artery band is good, but you use that for Swiss cheese. Now, it's not wrong to say I got a one-month-old baby who's in congestive heart failure, is on a ventilator, is sick, is septic. All right, and then if somebody presents you with that, giving you all these little innuendos, you don't want to put that patient on cardiopulmonary bypass. Even today, there is a place for doing a pulmonary artery band. It's also not incorrect for you to say, well, you know, maybe these high places, you know, these great places, and close the ventriculoseptal defect in a 2.5 kilogram kid. In my practice, I would prefer to do a pulmonary artery band and come back in 3 months, take the band off, and close the ventriculoseptal defect. That's an answer. There's nothing wrong with that answer. Okay, there's a lot of ways of doing things. But you ought to know, have a plan, a reasonable plan. Surgical considerations, there's not much problem with the conal defect for the conduction injury. But the paramembranous, inferior and posterior inlet is most likely to get heart block. The muscular, not much worry about. Transaortic approach is right under the non-coronary, right coronary commissure. How do you know this? Because someone told you that when you did an aortic valve placement, right? That's the place where the conduction system is, same place. And then the incidence should be less than 5% for a VSD. Operative mortality is low. Older patients approaches 0. Two-stage banding and delayed closure, rarely indicated, but sometimes it is. And the morbidity is low. There are special considerations that you need to take into consideration when you're looking at an examination or when you're looking at a patient. One is VSD with PDA. You can do that all from the front. Another one is VSD with aortic insufficiency, and I'll show you some slides of that. You can all do that from the front, and you can fix the aortic valve instead of replacing it. Another one is VSD with a coarctation. This is a little controversial. My hands, I'll take the baby and do it from the front, circulatory arrest, bring up the the descending aorta up underneath the transverse arch and do an extended end and anastomosis, and close the VSD. Some people will fix the coarctation, put a pulmonary artery band on, and then come back in 3 months, take the band off and close the VSD. Acceptable. Some people will do a left thoracotomy, fix the coarctation, close the wound, turn the baby over, and close the VSD at the same setting. Acceptable. Okay? Some people will close the, fix the coarctation and do nothing to see whether the baby gets into heart failure or not. Acceptable. So there's a lot of ways to skin this cat. But you got to have an answer. I think if you are wondering which one people are leaning towards, most people are leaning towards doing it from the front, short circulatory arrest, extended end-to-end anastomosis, during the reforming stage, close the VSD. Most people are doing that. Okay? Doesn't mean you have to do that. VSD with bacterial endocarditis, you got to do something about that. Under those circumstances, you can debride the tricuspid valve and fix it, and close the VSD with pericardium. Use your sense about that, and you'll come up with a good answer. This is the, see the right coronary cusp, you see it, here's the left, this is the right non. This is the one that's a problem, and you can sort of read this up like you would a mainsail if you're going sailing. And this is what it's, sorry. This is what it looks like from another point of view of reefing it this way and making the valve competent. This usually works, and you can give a little trial and error, and you can make that work. This is from our experience. We wrote it, but you could put any institution with this. The types are right over here. Most of them are paramembranous. Some of them are conal. And then you can see that the death rate is 0.9%, and these patients are with severe pulmonary hypertension. The heart block rate is on 0.7%. Reoperation rate is very low, and significant residual VSD is less than 1%. What is the life expectancy when a VSD is inoperable? That's a good question. I'm going to give you an approximate answer. If you have a patient who all of a sudden has a VSD and has a 1-to-1 shunt, they do all right for a while. As soon as they develop Eisenmengers, it's about 1 to 3 years, and they're dead by that time. And then, in fact, those are the times when you want to do a lung transplant for those patients, bilateral lung transplant, close the VSD. Many of them don't survive past that. Good question, but I think that's the answer to it. Any other questions? Yes, sir.
That's appeared on RASIC in-service exam a couple of times.
Yeah.
Was at the end of repair the paramembranous VSD, complete left pocket is present, and redo the repair or put temporary patient.
Forgive me, I have so much disdain for that question. Everybody raises it every goddamn year, and I just go nuts about it. Are you from Boston? Aldo said this. Said it once. And I don't know, there must have been 10 people around. Who have you from Boston? Anybody from Boston? I guess when Aldo says something, everybody takes it down, and God bless him, I love the guy. He was wrong on this. You don't do that, okay? Sorry. The question was, after you have a VSD, you close the VSD, you come off bypass and heart block, you go back and do it again. Everybody asks that question. One person every year. No, there's no, you don't do that. And the reason is because if you did it correctly, hopefully it's temporary and it comes back, okay? I think what Aldo was referring to was that he, one time, knew that he put the suture perhaps in the wrong place, and he went back, took the suture out, and put it somewhere else. To me, that may have been it. Most likely it was that after second cardioplegia, and he came back, the thing recovered, and it was okay, and probably would have been okay with the stitch. But you don't go back on bypass. You don't go back and redo the VSD. You just the consequences.